Today we'll talk about women's health issues. This includes ATI Chapter 2 in your maternal child ATI book, as well as your Med-Surg book 23, 24, and 25. A little bit about human trafficking. Women are at very high risk for human trafficking, and they often seek medical care or pregnancy care, so we need to be aware of cues. Sometimes women have tattoos on their body that are very indicative of human trafficking. They may have a partner with them that seems a little bit overbearing, controlling. It's really important to try to ask good questions alone with the woman in order to get some answers about that. A little bit about infertility. So the risk factors are listed on the left-hand side of the slide. I do want to point out that older women are at increased risk, as well as those with a history of sexually transmitted infections. Specifically, pelvic inflammatory disease caused by chlamydia. That can cause scarring of the fallopian tubes so that those scars would occlude the tubes. In the male, it could be medical. It could be a history of some kind of an infection, like a mumps infection, or it could be some kind of an environmental or occupational exposure. To note here, it may be as simple as wearing underwear that isn't tight-fitting. So sperm require a lower temperature than the core body temperature. That's kind of why the testes are in the scrotum. The scrotum regulates the temperature of the sperm. So if a man wears tighty whities, it doesn't allow the scrotum to hang lower to cool the sperm off. If there's a problem with a sperm count in the male, the first thing that is probably done is counseling to wear boxer type underwear to allow more thermoregulation of the testes. For diagnostic procedures, when couples enter infertility treatment, generally the male will have the analysis first, those diagnostic procedures. They usually start with a semen analysis and maybe an ultrasound. And it's done because these procedures are less invasive than the procedures that a woman would need to have done. So a woman would have a pelvic exam, a blood test for hormone analysis, have a post-coital test to see whether the sperm have motility problems in the cervical mucus, maybe some ultrasound to see whether there's any structural defects. I want to talk a little bit about the hysterosalpingogram. This is done under fluoroscopy, so it's done in X-ray. And this is when they infuse dye up through the cervix, in through the uterine cavity, and they're looking for the dye movement out through the fallopian tubes, looking for a blockage. Hysteroscopy is usually done under anesthesia, and that's a hysteroscope, fiber optic scope placed up through the cervix in order to identify any abnormalities of the inside of the uterus. And finally, laparoscopy, that's an invasive procedure looking at, again, structural defects or any kind of abnormalities of the abdominal cavity and pelvic cavity. Fertility treatment includes lifestyle changes, so improving nutrition. Exercise may include alternative medicine, and we talked about the male avoiding tight-fitting underwear. Medical treatment includes medication that may stimulate egg production or ovum production. And you can see that Clomid that's the brand name, or letrozole can be prescribed for this purpose. We have to let our patients know that when they're prescribed medication to stimulate egg production, that it does place them at higher risk for multiple pregnancies. But there are other medications that can be used, like metformin. You may or may not have heard of metformin, but this is often prescribed for individuals that have type 2 diabetes. It's also prescribed for women that have PCOS, polycystic ovarian syndrome, because this disorder is associated with insulin resistance. And then the other medications may be antibiotics to clear up any pre-existing infections. On this slide, we talk about fertility treatment. The first is intrauterine insemination, or IUI, where they would instill a man's semen into the uterine cavity when the woman is ovulating. The second one is in vitro fertilization, IVF. This is when they remove eggs from a woman's body and mix it with semen of the partner or of a sperm donor in order to create those fertilized ovum, and then they're matured to embryos. The embryos are then transferred to the intrauterine cavity. IUI has a higher rate of success than IVF. And then there's gamete intrafallopian transfer, or GIFT. This is when those fertilized ova are placed in the fallopian tubes. On the right-hand part of the slide, we see some other terminology. There could be a donor for the egg or the oocyte. We could have a donor that donates an embryo. Gestational carriers are those that carry a pregnancy that has a donor embryo implanted into her. It could be the birth couple, it could be their genetic material. A surrogate mother, sometimes gestational carrier and surrogate mother are interchangeable. A surrogate mother may have her own egg and then a sperm donor of the couple seeking infertility treatment. And then a therapeutic donor insemination would be a donor who is providing a sperm sample for insemination into that surrogate mother or gestational carrier. I've said it before and I'll say it again. These clients need emotional support. Infertility is a devastating diagnosis. I have 2 nieces that are struggling with infertility right now, and I'm sure I'm only hearing part of their struggle. We need to teach clients about adverse effects, whether it's a adverse effect of their medications that they're prescribed, or if they've had some type of a procedure with symptoms that they should report. And finally, we've talked about genetic counseling. Also, we can refer to a reproductive specialist and a grief counselor if need be. Moving on to menstrual disorders, this slide just gives you some terminology. Amenorrhea, A meaning without, and menorrhea, menstruation. So amenorrhea is the absence of menstruation. We see amenorrhea usually during pregnancy. Dysmenorrhea is painful menstruation. And dysfunctional uterine bleeding could be menorrhagia, which is excessive, or metorrhagia, which is bleeding between cycles. Also, we need to talk about premenstrual syndrome, or PMS. There's also a diagnosis of dystrophic or dysphoric disorder. So this premenstrual syndrome is on a spectrum, and PMS is on one end of the spectrum with relatively mild symptoms, and PMDD is on the other end of the spectrum with very extreme symptoms. Moving on to endometriosis. this is when endometrial tissue is outside of the uterus. So this causes dysmenorrhea among women because the body is not able to get rid of that menstrual discharge. It may be inside the fallopian tubes that cause some scarring that lead to infertility. It could be on the outside of the bowel. So when that is shed, the body can't discharge that tissue, so it causes pain. It could be on the inside of the bowel that eventually causes some rectal bleeding. So diagnostics might be an H&H looking for anemia, could be ultrasound looking for displaced tissue, and oftentimes it's diagnosed through laparoscopy, and we talked about a laparoscopy in a previous slide. So we'd want to teach about their medications. Oftentimes women with endometriosis are prescribed oral contraceptives and iron if they have anemia, analgesics to manage that discomfort, and if they need a laparoscopy or other surgical procedure, we would want to provide and teach pre and post-op care. Next, we'll talk about menopause, which is the cessation of menstrual periods, and it's defined by a woman not having any menstrual period for 1 year or more. So into perimenopause, women will begin having irregular bleeding, leading to the cessation of menstrual periods. This is caused because there's not as much estrogen as there was before. So women will have some genital atrophy and vaginal dryness. You've probably heard of women experiencing hot flashes, insomnia, fatigue, depression, and of course the loss of fertility. There are also skin changes. The woman's skin becomes more thin. There may be some hair loss and also some breast tissue changes. Also, we need to know that because of the loss of estrogen or lack of estrogen, it places the woman at higher risk for heart disease. So that in menopause, women are just as high a risk for heart disease and heart attack as men are. Sometimes pregnancy can occur during menopause, making the woman think that she's actually in menopause, whereas that amenorrhea is due to the pregnancy instead. Estrogen is also protective of their bones. So with the loss of estrogen, women are placed at higher risk for osteoporosis. And we should be counseling women to consume adequate amounts of calcium in their diet many years before the beginning of menopause. There are hormonal replacements that can be done to take care of some of the complaints of menopause. Sometimes hormonal therapy like Premarin or Premarin cream that's applied vaginally can minimize the discomforts of these signs and symptoms. However, we need to teach about risk factors. These estrogen replacements can place the woman at higher risk for embolic events. And then there are bisphosphonates for osteoporosis that carry their own risks. Benign breast disorders, there are fibrocystic changes that occur in a woman's breast that may make their breasts feel lumpy and bumpy. There could be pain or tenderness. It's important that we counsel our patients that they should get their screening mammograms beginning around the age of 40. For a higher risk woman, it could be as early as 35 years of age, and they should be done annually. There are ever-changing guidelines with regard to screenings, not just with mammograms. And to stay up with the latest guidelines, you can look up on the internet the U.S. Preventative Task Force recommendations for screenings. If there are changes on the mammogram, the woman may have to undergo a fine needle aspiration biopsy or an ultrasound for further diagnosis. Breast augmentation can be done not just with older people, but with younger people. Nowadays, the implants are saline since those silicone ones ruptured, and some women had some side effects due to the exposure of silicone. Usually it's done subglandulally, but can be done underneath the muscle, subpectorally, and they're not lifetime devices. The life of those devices are about 10 years. So we have to teach about the risks. Any of those can happen after implantation, and we would want to teach about those signs and symptoms when they should contact their provider. Talking about benign pelvic support disorders. These are pelvic organ prolapse, and that can happen with the bladder, the vagina, or the rectum. And it's due to the vaginal childbirth with the stretching of those tissues, also with advancing age and atrophy of the tissues, but also could be due to poor nutrition and increasing body mass or obesity. We should be teaching the Kegel exercises, tightening up those pubococcygeal muscles, the muscles of the perineum, early on, especially after childbirth, to strengthen those muscles. We can teach bladder training, and we can teach some dietary and lifestyle modifications like increasing fiber, losing weight, avoiding caffeine and alcohol. Sometimes women are prescribed and fitted for a pessary, which is kind of like the diaphragm, only it doesn't have the that membrane, and it just helps support those pelvic organs so they don't prolapse. And in some cases, women opt for surgical repair for anterior and posterior colporophy or hysterectomy. And then finally, hormone replacement can help as well. Urinary incontinence is the involuntary loss of urine, and this is not associated with aging. This is abnormal, and we can help our patients by teaching bladder training and Kegel exercises. We can also recommend or ask the provider if the individual is a candidate for a pessary. Sometimes medications are prescribed, and again, lifestyle changes. There are surgical interventions for urinary incontinence, so we would do good pre-op teaching and pre and post-op care. Polyps can be either cervical or endometrial. They're just little pieces of tissue that grow up from the anatomical structure, and they're usually diagnosed either with a pelvic exam using a speculum, or it can be diagnosed using a hysteroscopy. Polyps can lead to heavy uterine bleeding or heavy menstrual bleeding, and these should be removed. They can eventually be precursors to cancer. So these need to be removed, and we would do good pre-op teaching and care as well as good post-op teaching and care. Uterine fibroids, also called leiomyomas, are benign growths. They're fibrous growths. Sometimes women have fibroids during pregnancy and can cause complications during pregnancy. Also, they can rapidly grow during childbearing years due to estrogen dependency, and then they'll shrink up during menopause. We're not exactly sure why this happens, and sometimes these can be managed with hormonal replacement therapy, uterine artery embolization, and finally surgical They can be surgically removed to preserve fertility, or they can have a hysterectomy. To note though, if a woman opts for a myomectomy, removing that fibrous growth, then she has a surgically scarred uterus. So if she were to get pregnant in the future, she'd be at higher risk for uterine rupture. Many times, women that have myomectomy are scheduled for a C-section to decrease the risk of uterine rupture during labor. Genital fistulas, if you remember from a previous lecture, a fistula is an abnormal opening between two anatomical structures. So there could be a genital fistula between the bladder and the vagina, vesicovaginal, the urethra and the vagina, and it also can be from the rectum to the vagina. So small fistulas can heal without treatment, but large fistulas require surgical repair. This would be decided by that provider. So based on the provider's recommendations, we would provide guidance and support and explain all the treatment options according to what the provider is recommending. If surgery is required, then we would do good pre-op and post-op care and teaching. A Bartholin gland cyst sometimes happens when there's a blockage of the Bartholin gland. They can become infected and cause an abscess. So when this happens, usually surgery is recommended. So we give good pre-op and post-op care and teaching. An ovarian cyst, the types are listed on this slide. Sometimes expectant management can be done, so watching and waiting, seeing what happens. Other times surgical intervention is required. So some are benign, fluid filled, not a problem. Others turn out to be solid ovarian malignancies. These can be diagnosed through vaginal ultrasound, transvaginal ultrasound, laparoscopy. Also to note on this slide is PCOS, and I know I mentioned that disease in a previous slide deck, polycystic ovarian syndrome. It's when there are a lot of cysts on the ovaries, and this can also affect hormones and hormone levels. Sorry about that. Typically, individuals with PCOS have some facial hair. They're prone to obesity, usually abdominal obesity, and they develop insulin resistance later in life. So that's usually treated with some medication and sometimes lifestyle changes like recommending weight loss and exercise. Individuals with PCOS oftentimes have fertility problems. This slide shows the risks for reproductive cancer. So early menarche or early onset of menses, late menopause, so going through the change of life at a later than average age, sexually transmitted infections, especially human papillomavirus that's associated with cervical cancer. The use of some hormonal agents can also increase the risk of reproductive cancer in individuals. Infertility, a family history, and lifestyle behaviors. So diets that are high in fat and also a lack of exercise can also increase the risk of cancer in women. First, we'll talk about breast cancer. And you can see on the left-hand side those non-modifiable risk factors like gender. Although men too can get breast cancer, it's just more prevalent in women. increased age, a prior history of cancer, and I talked about the other things there. Of note though, the genetic, that BRCA gene 1 and 2, oftentimes if a family member is diagnosed with breast cancer, they will undergo the BRCA gene testing and recommend that the family members also undergo that genetic testing. On the right-hand side of the screen are the modifiable risk factors. So nulliparity or delayed childbearing greater than 30 can place a woman at higher risk for breast cancer. Not breastfeeding for a year or more can also increase a woman's risk. Hormone replacement therapy, obesity, a high-fat diet, smoking and alcohol, a sedentary lifestyle, and vitamin D deficiency. So these are all things that nurses can counsel and coach their patients throughout the lifespan in order to decrease those modifiable risk factors. Breast cancer screening, usually we teach a woman to do the monthly self-breast exam and then encourage regular screening mammograms. So usually starting at age 40, women are recommended to go get their first mammogram. And as I mentioned on an earlier slide, those that have family members that have been diagnosed with breast cancer, their screening will start usually around age 35. So a mammogram is that regular screening, but it could also include an MRI, fine needle aspiration biopsy, FNA, a stereotactic biopsy, that's a guided needle biopsy, a sentinel node biopsy that just looks for cancer cells in the lymph nodes, and then looking at hormone receptor status. There are several surgical options, and these are based on how aggressive the cancer may be, as well as the size of the tumor. And this would be recommended by the surgeon and or oncologist, as well as whether any radiation or chemotherapy, endocrine therapy, or immunotherapy would be recommended to treat the cancer. So more likely than not, the patient with breast cancer will undergo a surgical procedure. So we would do good pre and post-op care and teaching. Post-op, we'd have to make sure that we assess the dressings and change the dressings as ordered by the physician. Oftentimes these women have drains, so we would have to change the drain dressings and note the color and the characteristics of the drainage. We also want to try to teach those arm exercises to help move the lymph fluid. We should be doing referrals. Women with a cancer diagnosis, this is devastating. So providing that emotional support and then refer them to support groups as well as oncology and any other physician needed. Some insurances will cover reconstructive surgery, so referral to a plastic surgeon for that reconstructive surgery. What's very important on this slide, that last bullet point, as a nurse, we should not take a blood pressure, take blood, or give injections from the arm on the affected side because of the interruption of lymph. This slide shows the warning signs of reproductive cancer. So blood in the bowel movement is an abnormal finding. Unusual vaginal discharge, persistent bloating, irregular bleeding, low backache, any of these could be a warning sign to reproductive cancer. So you should be aware of these signs and then report those to the provider when you're taking care of this individual so that they can then order appropriate diagnostic tests, hopefully for earlier detection. Next, we'll talk about cervical cancer during pregnancy. So this gets a little dicey because the woman is carrying a fetus in her uterus. During pregnancy, they would want to stage the disease, and they also want to determine the status of her lymph nodes. So oftentimes the woman will opt to carry the pregnancy to term, but every once in a while a woman would opt to discontinue the pregnancy in order to seek treatment. Most times cervical cancer is diagnosed when a woman isn't pregnant. So we would want to encourage a woman to have her first Pap test at age 21, and that's recommended by the U.S. Preventative Task Force. Pap tests are then recommended every 3 years. This has changed from many years ago when it was recommended that a woman have this Pap test screening every year with her gynae exam. Then after age 30, the U.S. Preventative Task Force recommends that a woman undergo this Pap test and HPV test every 5 years, and only do the HPV if there's an abnormal Pap test. We know now that HPV is associated with cervical cancer. So one of the most important things to do is to recommend the HPV vaccine early in life to help protect the woman from cervical cancer. We also recommend that males receive the HPV so that they too don't get HPV and don't spread the virus to their sexual partners. The treatment for cervical cancer is usually a colposcopy, and that's usually done in the office. So after a colposcopy, we would teach the client that she should rest for about 24 hours. She shouldn't have intercourse for about 2 weeks, and she should report signs and symptoms of infection and bleeding. Now, cervical cancer still happens today, but the incidence and the mortality is decreased due to that Pap test. And the Pap test just looks for changes in the cellular lining, and it's called cervical dysplasia. Management depends on the severity and the results of that colposcopy. So our nursing assessment should include risk factors, signs and symptoms, as well as a physical examination, the taking of a very detailed history, and then following up and making sure the woman undergoes that further diagnostic testing. I already spoke about education of the HPV vaccine. We want to encourage that among new moms, especially moms of teenage boys and girls, that it's recommended that these young kids get that vaccine. And we also want to counsel that women should be following up with the recommended Pap tests. This slide just shows the abnormalities. The left-hand one is a graphic, just an artist's rendition of that abnormal appearance of the cervix. And there's actually a picture of a cervical cancer taken during a colposcopy. Vaginal cancer is rare. Usually it's metastatic from the cervix, and therapeutic management includes radiation, laser surgery, or both, possibly radical surgery in addition to radiation if the cancer is very extensive. As nurses, we would assess for risk factors, take a good history, ask about signs and symptoms. Usually the patients are asymptomatic. And then we would let the provider know so that they could do a biopsy of any suspicious lesions. This is a devastating diagnosis because it's part of a woman's sexuality. So we would want to provide counseling or refer to counseling with an emphasis on sexuality counseling, and also refer to support groups. Vulvar cancer. This is most common in older women in their mid 60s to 70s. And this is cancer of the external genitalia, the labia. So usually a woman should have her annual gynae exam, and the examiner would visualize the vulva when they do a gynae exam. And then if there are any suspicious lesions, then they would do a biopsy. If it's found that the woman has cancer, then a radical vulvectomy is usually done, and that's removing those labia. So again, nursing assessment, and then providing education as well as information and emotional support, and support groups. Ovarian cancer is the 8th most common cancer among women, and it's most common between 55 and 75 years old. It's so highly variable, and unfortunately, it's usually not diagnosed until it's quite extensive in stage 3 or 4. And right now, there's no adequate screening test. So often women will come in with vague complaints like bloating, nausea, back pain, and when they're diagnosed, again, it's later in the staging. They would undergo laparoscopy for diagnosis. They may undergo a total abdominal hysterectomy, which takes out the uterus. Bilateral salpingoophorectomy is both tubes and both ovaries. And then they would take some biopsies of the peritoneal cavity looking for metastases. Usually chemotherapy is recommended for all stages, and possibly radiation. So again, vague complaints, and you'd be listening for those when you do your good history and physical exam. We want to promote early detection. We don't want to dismiss those vague complaints just as a part of aging, but we want to take these women seriously and recommend follow-up. We want to educate the client for risk reduction, so those lifestyle changes, avoiding smoking or quitting smoking, avoiding alcohol and caffeine, a well-balanced diet, low in fat, weight management, and exercise. Endometrial cancer is the 4th most common gynecologic malignancy. And this is just cancer of the inside of the uterus. Usually it's diagnosed with an endometrial biopsy. This is usually done in the office as an outpatient during their normal gynae visit if they have complaints. So client teaching after that biopsy is that they usually spot for a couple of days. They should have no intercourse until the spotting stops, and notify the provider for any infection or bleeding. Usually they have the results of that biopsy within a couple of days. Therapeutic management includes a hysterectomy and usually a salpingoophorectomy, but it can also include radiation and chemotherapy. So these patients require surgery. We do good pre and post-op care and teaching, and with endometrial cancer and the hysterectomy, we remove the ability for childbearing. So sometimes this is diagnosed earlier in a woman's life, and we want to provide emotional care, and also we can refer to support groups. And supportive listening, we just talked about that on the last slide. So this is just that nursing process overview of taking a good health history, doing a good physical examination, providing information like that just-in-time teaching, and providing emotional support, reminding you that it should be culturally relevant. Hopefully, too, the woman's partner is with them so that they also can hear this client teaching as well as hear the emotional support. They need it too.